Nice to see you. Okay, well, thanks for saying that. Good luck. My wife is here too, but I don't know. She thinks she went to the bathroom. She'll be up in a second.
So, good afternoon, everyone. I'm Jean Marsh. I'm the director of the Center for Qualitative Study, and this is, I think, our fourth Michael Davis lecture of spring quarter. And this lecture, we're delighted to welcome Dr. Stevan M, who is Professor of Psychiatry at the University of Illinois College of Medicine, and also Director of Global Medicine at UIC. For the past 20 years, he's conducted a program of research on trauma and migration-impacted populations. His research is to develop, implement, and evaluate psychosocial interventions that are feasible, acceptable, and effective in real-world contexts. So needless to say, Dr. Weine shares a great deal of interest with many SSA faculty who are interested in research in international context. And he, in fact, has many colleagues here. One of the nicest connections is our student, Barry Barton, will be a postdoc at UIC with Dr. Weine next year. And so we welcome you with great pleasure. Look forward to your lecture.
Thanks very much, Jean. Thanks very much, Chaz, for inviting me to come here and talk to you today. I can't believe you want me to talk for an hour. I'll see how that goes. But I have prepared something that's maybe close to that. Usually I prepare something that's 45 minutes, but it goes for an hour. So we'll see how this works. So I want to talk to you today about refugees and their mental health. Teju Cole wrote, who I heard lecture here. Did anybody go to hear Teju Cole a couple weeks ago? He was phenomenal. He spoke at the Logan Center. He said, every refugee is alike, but each generation fails refugees in its own special way. So we live in a time where there are more forcibly displaced persons than ever. Since World War II, 68.5 million forcibly displaced, of which 40 million are internally displaced, 25 million are refugees, and 3 million are asylum seekers. Of course, you know that most of these folks are living in low-income countries. Turkey is now the world's largest refugee hosting country with 3.5 million Syrians. Other popular countries are Uganda, Pakistan, Lebanon, and Iran. In Turkey, more than 3 million live in urban areas, and less than 8% live in camps. With limited access to housing, work, information, food, education, health, and mental health care, they're especially vulnerable. 40% of Syrian refugees' kids are enrolled in school, only 40%. And child labor is a major driving force in the lives of these families. Okay, let's disrupt this 30,000 feet above view to look closely at one refugee family that I got to know in Istanbul. It's a story of the mother who could not pray. So Mrs. P, a soft-spoken, covered Syrian woman, lives in a sunny one-bedroom walk-up in Istanbul's Esenler neighborhood, along with her husband, devoting herself to raising their 3 young children. She wears a hijab and once prayed daily, but since coming to Istanbul as a refugee, Mrs. P inexplicably found that she was unable to pray. Now I never pray, although it's an Islamic society here too, she says. It has become an issue for their children. Quote, they want me to teach them to pray. They say, Mom, why aren't you praying anymore? I say, I will, but I don't. Her husband is patient, letting her take time to figure it out. But it bothers her, so she brings it up with me during our interview in winter 2017. "Do you still believe?" I ask. "Yes, of course," she replies. I say, sometimes when you pass through a terrible experience, it can change your relationship with God. She replies, "Every time I hear the call for prayer, I feel guilty, and I ask myself, if I'm okay, why am I not praying?" After speaking with Mrs. P, I can see that emotionally speaking, she's very much not okay. She has symptoms of PTSD and depression. She doesn't sleep. She awakes with nightmares. She has fear, fright, trouble concentrating. She cries every day. Yet, typical of most Syrian refugees, she doesn't frame her distress as any kind of a mental disorder. She doesn't even link it with exposure to wartime violence, and she doesn't try to seek help for any of her mental health issues. Her husband works 10 hours a day in a factory. Most days, she visits an NGO in the neighborhood where she makes handicrafts and speaks in Arabic with other Syrians about their kids. She explains that her children are still very fearful. Quote, "Here there are Afghanis and Indians who dress in short black robes. If my children see them, they hide behind me and say, 'Mom, did ISIS come to Turkey?' I tell them these are different people, but they dress like them. My little son will not go into the room if the lights are off. I tell him, there's nothing here now. Look around. We're in our house and the doors are locked." He says, "Maybe they will come through the windows." Later I'll tell you more about Mrs. P and her family. In comparison to Turkey's 3.5 million, the U.S. resettled only 22,000 refugees this past year, which is half of the allotted ceiling of 45,000. How many Syrian refugees were resettled in the U.S.? Does anybody know? 62. A whopping 62. However, since the 1980s, 3 million were resettled, and this shows how. When I moved, these are the caps for every year, and you could see that they were, modest still, but more substantial. When I moved to Chicago in 1994, the cap was much higher. Yeah, it was 121,000. And overnight, Chicago became a city of 40,000 Bosnian refugees. Then Chicago seemed like the best city in the world to work with refugees due to strong leadership from the state, an excellent network of resettlement and mutual assistance organizations, one of which you worked at, and a tradition of mental health professional engagement. Now, 24 years later, the U.S. Refugee Resettlement Program has been sacked by the White House, yet refugee mental health is practiced all over the world, and it's led by UNHCR, by WHO, by international and local NGOs, by governments, though it's badly under-resourced. Today, I'm going to talk about challenges and opportunities in refugee mental health. I'm going to draw on some findings from 25 years of work. I'm going to review some key concepts and findings from the literature, and I'm going to share some personal stories and reflections. Needless to say, none of this work could occur alone. Research is a team sport. I have great collaborators, both locally and internationally. And I have had great support from the Fogarty Center and NIMH. Nowadays, the perception of refugees is distorted by fear-driven politics and media coverage. We hear that they're criminals, that they're potential terrorists, that they're traumatized beyond recovery. And of course, these stories are either completely false or tell only part of the story. Instead of giving into fear, we must acquaint ourselves with the facts and science about their mental health and let those inform sensible programs and policies. So here are my main takeaways today. Due to multiple trauma and displacement-related adversities, many refugees either have or are at risk of common mental disorders, by which we mean depression, PTSD, anxiety. Refugee families also carry with them resilient capacities, which they deploy to cope with adversity. Although the vast majority of refugees still have little to no access to evidence-based mental health services, several interventions have shown positive outcomes, but more progress is needed, especially regarding interventions for families. And interventions with families could be approached via a task-sharing strategy designed to mobilize multi-level family coping strategies so as to improve both child and adult outcomes. So by now there's been a great many surveys, and this shows some of them, of different refugee populations which demonstrate the presence of common mental disorders. And so what's the prevalence? A lot of studies show somewhere between 25 and 50%, which would be above what the kind of norm you would expect in a peaceful society. Most of these studies focus on PTSD, of course, but when you look at them, you see that depression and anxiety is just as high, if not higher. A recent study of Syrian refugees in primary care in the US found that PTSD was at 32%, but anxiety at 40% and depression at 48%. Not surprisingly, Syrian refugee families experienced high rates of conflict-related violence exposure. You will not meet a Syrian refugee in Turkey who hasn't seen somebody die right in front of them. But they also experience a lot of displacement-related stressors, discrimination, difficult housing, difficult work, limited livelihood options, and a lot of uncertainty about their future. But despite this high prevalence of mental health problems, most Syrian refugees have little to no knowledge and awareness about mental illness, about self-care strategies, about clinical treatment, and they express very high stigma related to mental health help seeking. Over the years, there's been different types of mental health interventions done with refugees. The strongest evidence you'll find, as shown here, is for cognitive behavioral therapy and narrative exposure therapy. There's some evidence for family interventions, for group interventions, for medications, but not enough rigorously designed studies that have been repeated again and again like these others. There's practically no research on community-level interventions, such as anything that would seek to increase community resilience, say. And there's practically no research on finance or work-related interventions among refugees, though there's a lot of discussion about that nowadays. The problem in low-income countries, as mentioned earlier, where most refugees are, is that there's not enough mental health professionals. There's not enough psychiatric resources or mental health resources in general to treat these people. So it's absolutely inconceivable that you could do any kind of population-level services based on traditional approaches using just mental health professionals, such as trauma-focused models. So in a humanitarian emergency, resources are even lower than normally in a low-income country. So we need to think about what are alternative strategies to reach people who suffer, but we couldn't reach through existing resources. So I begin to understand better why Mrs. P suffers after they tell me about their escape from Syria. So things got so bad in their village that they chose to go to Iraq. Things must be pretty bad when you want to go to Iraq, right? Their bus caravan was captured by ISIS. The men were taken off first. Her husband said, "They put bags over our heads, and I thought, that was it. We will die. I just wanted my children. No one knew what happened to them. Over the next few days, I saw death with my own eyes." Mrs. P says, "They kept us in one warehouse, and the men were in another. In front of the men's area, there was a room that had blood pools outside, huge machetes everywhere. When they fired shots, we thought they were executing them." She adds, "They had guns pointed at our heads. My little son was on my lap, throwing up blood from his nose and mouth. I asked the man, 'Brother, please let me get something for my son to stop the bleeding.' He said, 'You are not allowed to raise your head, even if he dies on your lap.'" Mrs. P confronted her captor. "He asked me why I was wearing trousers. I told him, Open my luggage. You will find my prayer mat, the Quran, and my dresses. Today's an exception. I'm wearing trousers for comfort only. Which prayer do you want me to name? Or which verse from the Quran do you want me to recite? Islam is a helpful religion, not a tough religion. Not by force, so did the Prophet preach. You want to force me to pray. I always pray, but now I'm traveling. And if you are a true Muslim, you know what that means. That was incredibly brave of you, I said. Yes, but then he put me in a room by myself and locked the door, so I was more scared. 4 hours later, they took her back to the rest of the women. After several hellacious days, they were miraculously released and returned by bus to Syria. They decided to head for Turkey and were smuggled across the mountains, eventually reaching Istanbul. Mrs. P did not know what had changed inside of her. I asked myself, is her not praying some kind of post-traumatic phenomenon? She was unable to close her eyes, to focus and concentrate without being flooded by memories and fears. She was avoiding the solitude of prayer, which instead became a repeated confrontation with her ISIS captors and their theological arguments against her. I don't know the answers, but before I go, I share with her some slow breathing exercises in hope that they would alleviate her symptoms. More later about this mother and her family. What I want to do now is give you an idea, an overview of how refugee mental health has approached these issues over the past 30 years. Refugee mental health has been approached from 3 paradigms: trauma, psychosocial, and global mental health. I'm going to briefly tell you about each perspective and some of the work that I've done in each of those spaces. So back in the 1980s, the psychiatrists Richard Malika, David Kinsey, Joe Westermeyer developed specialized community mental health clinics for refugees in Massachusetts, in Oregon, and Minnesota. And they were all focused on providing PTSD treatment. And so when in the early 1990s, the huge wave of Bosnians came to the US after ethnic cleansing, concentration camps, and siege, in some sense they fit very well with this model because they had a lot of trauma exposure and a lot of PTSD and depression. So in New Haven, Connecticut, where I was at the time when the war and ethnic cleansing happened, and where some of the first refugees started coming to Connecticut, strangely enough, we conducted a longitudinal study of newly resettled Bosnian refugees. We interviewed them like within weeks of their coming, and then we followed them for several years, both kids and adults. And this is from one of our papers of all of their story or their symptoms. We also took testimony from them, which is another story. But the level of PTSD diagnosis in them was 65% initially. And it remained substantial 1 year later after their resettlement in the US, although there were some decreases in level of intensity. Older refugees appeared to be at higher risk of continued bad symptoms. In Chicago, UIC formed the Bosnian Mental Health Program with Heartland Alliance, at Heartland Alliance, and we provided trauma-focused mental health treatment to Bosnian refugees. At the same time, there were obvious limitations to this trauma model. Ken Miller and I showed that whereas exposure to war-related violence was high and very predictive of their outcomes of PTSD, depressive symptomatology was accounted for by all of their displacement stressors, by all the things that were happening in Chicago. And there were a lot of things happening in Chicago that were bringing them down, like, for example, trouble with their kids fitting in and trouble at school, that kind of thing. And also, though I personally treated, I would guess, 1,000 Bosnians over those years, we know that the vast majority of those suffering never came to our clinic. We estimated that 8% of Bosnians got mental health treatment, but 65% had above a clinical threshold of PTSD, so that's a big gap. I got to know many as colleagues and friends, And yes, there was PTSD, but there was also a great deal of strength, black humor, music, soccer, basketball, and alcohol, which helped people get by. At one point, we decided to do a study comparing the clinical sample versus a community sample. And it's a little blurry, but this is the results. So a total of 70% of the non-presenters, let's say it differently, 100% of those who presented for services had PTSD. 70% of those who didn't also had PTSD. That's pretty high. They were matched on demographic characteristics. So the ones who were coming for service, they weren't matched on demographic service because we wanted to understand demographic variation. And the ones who came for services were much more likely to be women and middle-aged. Also, the group that didn't present for services had a little bit less intensity of PTSD and depression, as you can see there. And those refugees who didn't identify with the sick or patient role as readily as service recipients, they were having, so the people who weren't coming, they just didn't see themselves as sick. They didn't want to be seen as a patient. And they tended to be more functional. They were more engaged in work, in family, in the community. So that left us, yes?
Clarify what the services were at, what was the agency?
Heartland Alliance.
Oh, okay, all right.
Yeah.
So
In
the
their
name
name,
of the service wasn't mental health, it was Heartland Alliance Program for Refugees?
yes, something like that. I mean, on paper it was the Bosnian Mental Health Program, but it wasn't promoted that way. And it was, really friendly, in their community, free, run by Bosnian bicultural workers. There were groups, there was individual, I mean, we tried to diminish as many of those obstacles as possible. So what we concluded from this is that you're never going to get those people to come for these kind of services. And we needed to do different kinds of innovative access, engagement, and preventive interventions if we wanted to try to reach the people who weren't coming for those services. So we also conducted qualitative research with Bosnian refugee families, and we learned how they demonstrated what we would later call, or what Froma Walsh would call, family resilience. Here's one story that I found particularly striking. So at our first meeting, 12-year-old Yasmina spoke of how she and her family worked to stay plugged into a continuation of a proud, authentic Bosnian experience. Quote, "I still keep thinking about what would have happened if there wasn't a war. How would I live? I wouldn't be living here. I'd be living there all my life and growing up as a real Bosnian and not in a foreign place." And real Bosnians meant staying connected with the people, the values, the place, and the culture. She explained to me the kind of work a young person does to keep herself connected with Bosnia, even as she's making it in Chicago. "Do you know what a muse is? I have 2 muses. This one is my bear. I got it when I was 4. He came from Switzerland. This bear has been with me all my life. He went with me to Germany. He went with me on the airplane. He's just been with me all my life. I keep resewing him. He's my pal. He's going to be really old." And I thought resewing is a good word to describe what Yasmina was doing. She was part of a family strongly rooted in history and culture that was now trying to survive in new conditions. In her family, she was the prime bearer of its memories, knowledge, and pride. And she needed to keep them with her, even as she grew and became more American. In her bedroom, she pointed to the large doll atop the boombox on the highest bookshelf above her desk. "I like that doll because my grandfather gave it to me for Bayram. That's a holiday, so he gave it to me, and I really like it. When you turn her on a musical box, she plays Beethoven. That doll reminds me of my grandfather because he passed away. Like his spirit is there, so he kind of keeps watching over me." If you're a young girl in a new country, it's good to feel watched over. And in this family, that happens on a daily basis. Every day when the kids get home from school, Yasmina's father sits around and eats with them. Their mother gets home later after 6. Then Yasmina said, we're all together. I asked who does the cooking. I do, said the father. I have nothing else to do, so why not? I make bread very much. I make fresh bread. In a cabinet of the media center, the father keeps a collection of videotapes of music and dance from Bosnia. He and Yasmina and her brother were watching one day a tape together when I walked in. He explained that this was an important dance group and an important singer who sang traditional songs. And the family had lots of tapes, and they would watch them all the time. And Yasmina said, I like to watch them. I'm very interested in that kind of music, as well as others, rock and roll, rap, and hip-hop. None of this would be possible were it not for all the family was doing to support it, like protecting family time, balancing work schedules, engaging with schools and teachers, teaching the Bosnian language, sharing music and tradition, and being involved in the community. They were nurturing the cultural capital associated with being Bosnian at the same time as they were adapting beliefs and standards associated with success in America. This story gets us thinking about the psychosocial paradigm, and especially, as I said, resilience. So resilience has been defined this way: positive or adaptive outcomes in the presence of some type of risk, stress, adversity, daily life challenges, or trauma. Resilience can occur at any level: individual, family, organizational, community, cultural, societal. And then we have the idea of family resilience, a product of family relationships where hardships and challenges are opportunities for healing and growth. And of course, Froma Walsh has defined resilience as in families as being really based on these three pillars. Family belief systems that say that something good is going to come out of this, no matter how bad things get. And those belief systems are often rooted in faith. Flexible family organization, the ability to roll with changes. The dad can make bread and stay home. You don't have a patriarchy trying to defend itself against change. Open communication processes, especially around negative emotional issues, around trauma stuff especially. We conducted qualitative research listening to hundreds of Bosnian families and built this model, which we called FAMCORT, Family Consequences of Refugee Trauma. Our challenge was that trauma has been in the American context so much conceptualized as an individual family, but these people were living their lives as families, and they experienced trauma at the family level. So what does that mean? So using a grounded theory approach, we made this model, and what we found is that there were really two constructs that emerged from listening to them. The first construct is displaced families of war in that middle column. These are all the bad disruptions that trauma brought to their family, and you could see what some of those are. But as they also spent half of their time talking about all of the good ways in which they had been coping with these things. And they put equal weight on that. And we called that families rebuilding lives. And so we were very impressed at the way in which they were coping at a family level. And we used these kinds of, let's say, processes, family processes, as ways to sharpen our interventions, which we did with families, and as also ways to try to develop measures to measure some of these processes. We didn't use the word family resilience back then, but I think that's what it was. So what we did is we decided to develop a prevention and access intervention for refugee families that we called CAFES, Coffee and Family Education Support. And it was built on a multiple family model of refugees who had at least one person in their family who had symptoms above a certain threshold, like PTSD symptoms. And this was a group that was run by persons who were refugees themselves and not mental health professionals. They were trained and supervised by us. The group met for 9 sessions. This is like the model that we built that inspired that intervention. And we called it a prevention and access intervention because it was trying to do two things. One is it was trying to promote access. So here you have say you have an individual in that family who's vulnerable. Say they have PTSD symptoms or depression. They're in the family, and the family is trying to access these systems. What we hear again and again from refugees is, we don't know where to go, and in any case, we don't trust them. So we basically stay by ourselves. And so we thought there was need for an access intervention to try to overcome those obstacles, to connect them with resources. But then we also thought it's a prevention intervention because we thought families themselves may be able to solve some of these kinds of problems, and maybe we could strengthen some of their existing coping strategies in a way that would help them. So that's what the intervention tried to do. It was trying to work on 4 different things. Networking, so linking them with other families, organizations. Knowledge, giving them knowledge and skills to strengthen themselves. Support, that's both in support within families and support between families, and improving communication. So in the end, we had some good findings on the access intervention. We showed that we conducted a randomized controlled trial. It was funded by NIMH with 18 months of follow-up. There was like 125 families in each group. And this group accessed mental health service. The people who went through the group accessed mental health services much more than the others. They also accessed other services too, like, for example, dental services. So what this meant is that we were able to overcome some of those access barriers in the group. And we showed that it was through not just knowledge, but changing family communication. That was a critical variable. The family being able to talk together about difficult topics such as trauma was the significant mediator of this change. Another mediator was depression. So in those families where there was more depression, people accessed services better. So that makes sense. There was more need. In terms of a prevention intervention, the findings weren't as strong. There was some improvement in PTSD amongst men who were depressed, but they weren't all that remarkable. I want to emphasize one other thing. Engagement was a critical issue, as it always is in these kinds of projects. We had really good engagement. So there were 9 sessions. This means that I think 73% of them came for 7 or more sessions. That's pretty good when you consider the weather and childcare and school and transportation and money and all the things that get in the way. But one reason why we think that was good is because we did qualitative work and developed scripts that our recruiters use, that our group leaders use. And here's one such script. Most families struggle over how to live with memories. In cafes groups, we don't expect people to tell their trauma stories. Don't stay away from the groups because you're afraid of talking about trauma. Come to the groups because there we help people to think about what are the best strategies for living with traumatic memories, including not talking about them. This is one of the fears they have. The other fear they always have is, I don't want people to get into our business. Why do I want them to know about our family? And so we say to them, you don't have to say anything about your family. Just come and listen and learn. And you may be able to help other families, but it's completely up to you what you want to disclose there. There's no pressure whatsoever. These things made a difference. Now, I want to say that this psychosocial approach that we chose there was very deliberately not focused on treating common mental disorders, including PTSD. Nowadays, 2019, I would say that was a limitation that I think that was a mistake. But I want you to understand where we were coming from. At the time, this is like late 90s, there was a backlash against trauma PTSD focus as being too medicalized, too much of a Western construct. To Derek Summerfield, it was a medicalization of suffering. Patrick Bracken called it an overly cognitivist and Cartesian perspective. And there were different models coming up then. Post-traumatic growth, which I'm sure you know about. People didn't really use the word resilience back then, but more positivist, not positivist in that sense, but positive models. And so we were taken by that. And about the same time, the IASC came out with its famous triangle, which really, anchored psychosocial interventions. Interventions that are strengthening community, family, and support. This is, where most of the work should happen. Sure, some people need specialized clinical PTSD services, but we clearly saw cafes as being down here. This is where we wanted to be. We thought we could help more people down here. So that was Chicago. At the same time, I was working some in Kosovo. And the situation is very different in low-income countries. In Kosovo post-war, the CDC's Barbara Cordoza did a study of PTSD, and it demonstrated psychiatric morbidity at 43%. So 43% of a population of 4 million had some diagnosis. Yet, there were 19 psychiatrists. There was no functioning mental health system. So how could they ever be treated? At the time, we made a very difficult decision to focus resources there on treating the chronically mentally ill, because there was a great need for them. They were being locked in closets at home. They and their families were highly stigmatized, and we thought if mental health deserves to exist in Kosovo, it has to first do something about the chronically mentally ill. So we took this multiple family group model, which, truth be told, we originally stole from, the work that was done with families of schizophrenics. I forgot the guy's name at Columbia University who developed that model. I met him in medical school. That's where the multiple family group model in psychiatry began. So we kind of went back to that and said, let's build that. And so we had that group run by doctors and nurses. And we found that it was effective. Here's a picture of the families for one of the group. We did some quantitative studies and some qualitative studies, and we showed that it had really big effects on improving compliance, improving symptoms, improving attitudes, improving the relationships with the mental health centers. And so we used this as, I worked closely with the leader of psychiatry and with the leader of, the Ministry of Health. And at the time, we were involved in building 7 community mental health centers in Kosovo. And this model became the kind of DNA of the emerging mental health system, which they very much wanted to be family-focused, building on their family values. And so I'm proud to say that on a very small amount of money, I think $199,000, we built this thing, and it still exists today. They're still doing this. And they've taken the same model and adapted it to other problems like suicide, like drug use, same multiple family group model. And this is us a few years ago with a kind of reunion, bringing the whole team back together and talking about how this worked and what remains. So, and here's a quote from Farid Agani in the New York Times, 2012. Our needs were very high. The human resources to respond were very low. The natural answer was to rely on family structure. Families are very strong here, very connected. Before, our model was centered on medication. We wanted to train teams in providing complete services based on family resilience. What could be better than having this resource? Indeed. So we now live in the global mental health era. And the global mental health paradigm, which really appeared in the early 2000s, came about especially through the leadership of Vikram Patel, the Indian-British psychiatrist who's now at Harvard. I hope you're familiar with his work. And this is all about providing mental health services in low and middle income countries. You know, the global mental health field tried to learn from the HIV/AIDS field, which did the impossible. Who would have ever imagined that every poor person in Africa would have access to antiretrovirals and prevention treatment, but it became true. So whatever they did right, we need to try to do right in the mental health and psychosocial space. And that's what the global mental health movement is all about. But when you work in countries that have practically no psychiatrists, psychologists, or social workers, what are you going to do? You need a new model. And so that model is task sharing. Task sharing is a process of task delegation from doctors to nurses and from nurses to other less specialized health workers. And one of the pillars of that model has been this whole MH-GAP initiative of the WHO. And so what this model is saying is that, look, 14% of health morbidity is explained by mental health problems, especially depression. And yet 70% of people in low-income countries don't get any help for what they need. That's the gap, 70% not getting the help that they need. So what can we do to close that gap? So the challenge is, can we develop evidence-based interventions that could be implemented by non-health specialists and scaled up at a population level? And two of the interventions that have been used are here. One is interpersonal psychotherapy, developed by Myrna Weissman and others, which has now been done in Uganda, in Kenya, in Tajikistan, we did it, and in other low-income countries, and always implemented by non-specialists and also implemented in complicated scenarios like HIV positive, for example. Do you know interpersonal psychotherapy? The model of interpersonal psychotherapy is all about addressing the social determinants. And like if people can find a way to better problem solve around the interpersonal conflicts and transitions in their lives, they can decrease the stress upon them and improve their mental health symptoms. And then another intervention is PM+, Problem Management Plus. There's a suite of interventions that the WHO has developed, which basically is taking cognitive behavioral techniques and kind of dumbing them down and making them things that you could teach people to manage their own symptoms in a very rapid way. So it's done one-on-one individually in like 6 or 8 sessions, or it's done in a group setting with adults or kids. And there's been several randomized controlled trials of PM+ that has been found to be effective in humanitarian emergencies. How do all these things fit together? This is a figure that comes from the World Bank in Ukraine. And so it's the same triangle model. So okay, at the top you have specialized psychiatric services. But before that you have psychological treatment, the psychosocial support and counseling, self-help and peer support, community recreational and social activities. I think that in the old days, we were way too much focused up here. Now there's a deliberate strategy of providing all these multiple tiers of support. And the things that I just mentioned, PM+, those are probably somewhere around here. So I had been following the work that was going on in Syria, with Syrian refugees in other countries, and Turkey, Jordan, Lebanon, European countries. And much of the literature I found was the same old stuff of very individually focused, what's their rates of PTSD and depression, And I thought, kind of depressing, we're just repeating the same old individually based models. As a way of trying to jumpstart something different, we decided to do a small qualitative study, and this is our team on the right, that went to Turkey and we interviewed 30 Syrian refugee families in their homes for several hours. And then we went back one year later or so and did it again. This analysis identified a total of 22 war and displacement stressors for families across 3 categories. Qualitative study. So surviving war and border crossing, all the kinds of things you would imagine. Living in Istanbul, poor finances, children working not in school, difficulty finding apartments, hard working conditions, discrimination. Parenting in Istanbul. Children have to work, can't attend school, can't get registered. Parents can't help them with homework. These are, as Teju Cole said, these are the same kind of things we saw in Chicago. But the analysis also identified 16 family coping mechanisms, which were a little bit different from what I mapped out before. For example, here, making the best of living in a new country, which seemed to be their attitude towards Turkey. Look at some of these things. Family solidarity and support. Women's empowerment is welcomed. Mothers set a positive emotional tone. Spouses share and support one another. It's God will and a test for us, the single most often heard statement. Hoping children will have a better life. Praying and the Quran brings strength and relaxation, except for Mrs. P. Families maintain contact, send money to Syria, teach Arabic language, plan to reunify. They share good times in Istanbul. Let's look at a few quotes. We're all working and supporting each other. We don't distinguish who brings income and who does not. We share everything, income and expenses. We like and have to help each other. Before I used to depend on my husband. Now I have to depend on myself. Before there were things I couldn't do, but as a result of circumstances, I'm forced to do them. Slowly you become stronger and stronger without realizing. They tell me about their problems. If they're upset, they tell me. They tell me everything. If they are not happy or anything. I can see they're exhausted and try to spread joy and happiness for them. This is what God wants. It happened. It's impossible to change history, but thank God we are going and living with the flow. This was written by Allah, and we have to follow that. My son here feels that his brother in Germany is not good, so he stays up and keeps talking to him until he makes him feel better. They respect and obey their father in Syria. We discuss everything together as a family. We take decisions as a family. We meet on the internet. We discuss the issue. We agree on one thing. Special cooking of special dishes is done on Sunday, and we eat together as a family. On Saturday, we go to the park and play soccer with other families from our town. In Turkey, there's less risk to harm our values than other countries. Turkey is more conservative than other countries. We have the same religion. They didn't ask us here to change our values. So what are some of the priorities that we take away from that? One is, I think, after visiting all these families, you're just struck by the great difficulty of kids not attending school and having to work. And if there was one thing we could want to change, it would be that. Another takeaway is how important faith is to these families. And they're not all religious in the same way, and there's different degrees of devoutness. But putting faith into our psychosocial interventions or building bridges between those would go a long ways to improving access or the acceptability of those, I think. And then again, we saw evidence that we should develop, what we would call low-intensity family-focused interventions that could be conducted, say, by NGO workers or by primary care nurses. Because we talk to a lot of NGOs, for example. They do great handiwork stuff. They do great language stuff. They prepare them to find jobs, but they don't have any mental health or psychosocial services. They could easily be doing those in those same rooms and between their other groups. But one of the things that really confronts me as a challenge when I think about doing family interventions is the intense variability in refugee families. So let's just say you put together, let's say you were a group of refugee families, okay? We had you here today and we were going to try to do some kind of intervention with you. Just think about all of the heterogeneity, variability in this room. So who in the family is vulnerable? It could be the mother, the father, the sister, the brother. What kind of mental health problem do they have? It could be depression, anxiety, PTSD, or any other thing. What kind of family structural problems are they dealing with? Who have they lost? What kind of separation is there? What kind of family processing issues are they struggling with? Emotional regulation, communication support. And how are they doing with coping strategies? It's very hard to think about, or very challenging for me anyways, to think about how to design intervention that would meet most of your needs if you were those families in the room. The only way I can think about that is by thinking of the principle of multifinality, or many ends, which is that similar initial conditions can lead to very dissimilar outcomes. So any one component can function differently depending on the organization of the system within which it operates. So what that tells me is that family characteristics can impact individual outcomes. If we can do anything to change those family characteristics, we should try to do that because they could improve their depression, anxiety, PTSD, possibly. It tells me that we shouldn't just be doing CBT. CBT, it's easy to do CBT, and we should do CBT, but we shouldn't limit ourselves to its safer ground, kind of scientifically. Interventions should also try to strengthen key family resilience characteristics. So we made a kind of low-intensity family support model. And what we did is we tried to combine the CBT stuff of PM Plus with the family resilience training of cafes, and we took some of the interpersonal psychotherapy problem solving, but instead of making it individual, we made it family. And so, so this shows the model. And it's task sharing in the sense that it could be implemented by nurses or NGO workers. And so the idea is to mobilize multi-level family coping strategies to address multiple outcomes of adults and children. So we're doing 4 things simultaneously in this group. We're doing stress reduction strategies to get at those. So this is the thing that we didn't do in cafes that I regret not doing, that we're doing now. We're doing family problem solving strategies to improve family communication support, psychoeducation strategies to increase knowledge and attitudes regarding mental health and to challenge stigma, and linkage to care strategies, access to mental health services for those who need and want that kind of thing. There's many challenges involved in doing this work. So who are the local academic partners in, say, in Turkey who have research capacity, including with implementation science? What you find amongst those partners is they tend to be much more clinically oriented. And why do they want to give that up for a project like this when they're trying to build themselves? You see a lack of partnership between academic and humanitarian organizations in that space. You have people who don't really want to get on board with the task-sharing model. They're trying to improve the lot of mental health professionals. Why would they want to put themselves out of business by teaching others how to do that stuff? There's an issue of the cultural competency of local and U.S. partners for dealing with Syrians. There's an issue of getting them to focus on the humanitarian emergency in their own backyard. Turkish people have plenty of needs too. And there's so many social problems that are just inconceivable to solve right now, such as the problem with children not attending school. But we formed a project. We got NIH funding. We have a partnership with Istanbul Medeniyet University with the Turkish Red Crescent with 6 NGOs, and we're developing this. The first thing we did is we formed a design team of academic professionals, community-based organization staff, and community members. And we convened a 2-day workshop. We looked at a lot of evidence. We looked at our qualitative data. And we made this conceptual framework. And we outlined the intervention manual, or the intervention model. We spent 6 months drafting the manual, and we piloted it a couple of times. This is what it looks like. It's 4 sessions of about 100 minutes each. Each session begins with coffee and welcome. Things like, so in each of these groups, you could see there's a kind of CBT element and there's a family problem-solving element. So for example, this is teaching them our responses to adversity, slow breathing, and then family problem-solving, how to deal with family emotions. At the end of each group, the family makes a plan. They do a problem-solving plan. What problem do we have in our family that we want to try to solve? And they make that plan. We do Get Going, Keep Doing, which is an evidence-based intervention for depression. We teach them grounding. For part of each group, we break up the adults and adolescents. We're having adolescents 12 and above in this group. Other kids are not going in this group. They're in the next room with the babysitter because we think they're too young. So that's what we're doing now, and we're piloting this. Let's see. Can I go 5 more minutes? Okay. So let me just give you a little bit of sense of what we say to people in the group. It's all in Arabic, obviously. The goal of our group is to help strengthen families. We regard the family as a Syrian people's most important and dependable resource. In our faith, we consider the family as a foundation and key to a healthier mental, emotional, and spiritual life. Because of this, we'll focus on issues in the family that will help all to adjust better to life in Turkey. We'll work on problem-solving and communication to help your family better approach the challenges you face. We'll also help you to manage emotional distress in adults and adolescents, such as feelings of hopelessness, fear, sadness, or worry that are common for people living in difficult circumstances. Notice we're trying to stay away from diagnosis and mental health language. Emotional distress, that was what our focus groups and stuff said was an okay way to talk about this. Here are some messages we send to them. First and foremost, we tell them talk. First and foremost, you and your family need to be able to talk about these challenges openly. This can be a stressful topic, but not one too stressful to talk about. Not talking takes the power away from you and puts it in the hands of fear and anxiety. Make plans. Being a Syrian in Turkey is another area where we can use the action plans we talked about last week. If difficult questions come up, like kids asking what will happen to us when the war ends, or when other students stop teasing me in school, these deserve answers, and you should try to make plans around them. Remember your worth. Sometimes it's not easy to be a refugee. Often we are the target of a lot of negativity. It's important that we don't give in to that prejudice against us as Syrians. We should not accept the mentality that we don't belong in this country. This is all part of a divine destiny written for us. There's a lot of spirituality. There's a lot of religious aphorisms. We talked to Islamic scholars. We talked to imams. They helped us with this. Here's some. So the Prophet Muhammad once said, whoever is pleased to have his provision expanded, his lifespan extended, then he should keep good relations with his family. We had another one about aggression, against aggression. It was actually hard to find good quotes. I felt that a lot of them were, I don't know, a little too harsh and a little too kind of rigid. But we found enough good ones. We have exercises like we give them like tasks to do. So you feel that your family's not spending time together since you have arrived in Istanbul. Occasionally you're having Sunday gatherings for lunch, but even that lately is not taking place as children are preferring to spend time with friends and be outside. Try to think how you can increase the quality time by spending time together as a family. Try to suggest activities you can do at home, out of home. Discuss also the impact of seasonality, like things you can do in winter and summer. So we'll give this to them and say, take 10 minutes, figure it out, tell us what you've figured out, and all the families share together. So there are implementation challenges in this model. One is gender issues and group participation. We have mixed opinions about men's role in the group. We know that it's going to be hard for the men to come every time. The compromise that we have at present is we're going to have the men come for the first and fourth groups. That's required. The other ones, they don't have to. We feel that's better than saying come every time, because then we feel like they won't. But we're going to make them agree to come those. And then what we also do after the other groups is we give the kids homework to go and show to their dads what they learned in the group. We also have YouTube videos of all the important group content, like how to do deep breathing and stuff like that anybody could access on YouTube, done in Arabic. And we have a handout. So we have these kinds of tools so that people who don't come can still access this. One other challenge is if they need more mental health care, where are they going to get it? There's some pretty good NGOs where they can get care, and we've developed a list of resources, but it's not easy. So we're enrolling 72 families with at least one adult or adolescent with significant emotional distress, and we're doing pre, post, and 3 month later assessments, and then we're going to conduct qualitative interviews. And this is starting right after Ramadan. Of course, there's other bigger challenges for this kind of intervention. How will you scale it up? Let's say it is effective. How to scale it up? How to sustain task sharing? This is like the big, unanswered challenge in the room. How do you take these people? Like we have interventions with peers that we do in other contexts. People who are not part of the system, people who are not paid. What's in it for them to keep doing these interventions? Does the system need to pay them? How do you support their secondary traumatization and burnout, for example? And I think a really big challenge is how to use digital technology. Everybody has a cell phone. How can you use that to augment a task sharing model? Okay, I'm going to wrap up, but I'm going to first tell you about what happened with Mrs. P. So 7 months later, I returned to see Mrs. P and her family. They're welcoming, as if seeing an old friend, and they make me tea. Mrs. P has been practicing the slow breathing exercises, and they helped her to feel more and more like herself. But they aren't as good as praying, which is what really helps me to feel purified and relaxed. Mrs. P has less nightmares, fears, and flashbacks, but she's still not praying. Her husband says it's her personal freedom to decide. This time she tells me how she was beaten and threatened with death after talking back to ISIS. She recently concluded, "My belief in my religion is different from theirs. I was right about Islam, not them." Now when she hears the call to prayer, I feel I could. I mention God and remember God many times every day. I ask, what do you think is the main reason that you have not been praying? Is it like the identity issues about your Islam versus their Islam? Or is it the emotional issues around your troubled feelings and memories? Actually, it's both, she said. I overcame difficulties, and I got convinced that my belief is the right one. And then she taught me something interesting. Quote, "The most important thing for me is the heart, that it is purified." So in Islam, if I've got this right, the heart is regarded as home to both emotions and intellect, as well as faith and the soul. Despite all their hardships, she's at work on purification, and her heart is good and it's getting better. Just before I say goodbye, she pulls me aside and says, "I thought I was going to pray this week." I think she really wanted to show it to me. Although there's a lot that I didn't understand, I believe that listening to her problems and teaching her slow breathing made a fundamental difference. I didn't need to understand everything but just doing those things, I think, helped a lot. So maybe one day soon, her children will stop what they're doing, and they'll see their mother remove a prayer mat, kneel, close her eyes, and pray again. So in conclusion, the families of this mother and Yasmina from Bosnia and countless others have made me a believer in the family and their resilience. I see how they can draw on strengths and resources to cope with multiple traumas and displacement-related stressors and symptoms. And I see how we can assist them in expanding on those coping strategies. In an era of 65 million displaced persons, one potentially promising strategy for helping many is through low-intensity family support, which mobilizes these kinds of family coping strategies. Teju Cole says, let's not throw ourselves into paroxysms of self-congratulations for these small advances of science and humanitarianism, and let's work harder to resist the forces of society which generate and then denigrate refugees. Lastly, what could U.S. mental health professionals do, like yourselves? I think we could work with local refugee resettlement agencies and humanitarian agencies who need your partnership and support. Could shift from a narrow trauma-focused model to a broader psychosocial or global mental health paradigm. Could build and evaluate new evidence-based models to help refugees like Mary's doing. Could advocate for refugees and for the programs that work with them. And could focus all the same attention that we've focused today on refugees to migrants and asylum seekers who have many of the same challenges. Regard neither as strangers, but all as kin. Thank you.
Thank you, Dr. Lang, for a great talk. I'm sure we have some questions, and we have a few minutes. So let me start. I was delighted to see your reliance on social work scholars like Donald Walsh and Weine. I'm interested in your ideas about social workers in the workforce in this new era of refugee and migration work.
Why not? I mean, we need a workforce. There are not enough people who are focused on those issues, for one. There are not enough human resources, there are not enough capital resources. And I would say that the mental health, as I've shown, the mental health approaches that have been utilized have been too psycho and not enough social. And so we especially need innovations in the social area. And I expect that if somebody is here talking 10 years from now about refugee work, they're going to be talking more about family stuff, more about community stuff, more about innovative work models or school models. So it's the integration of the psycho into a variety of different social contexts. And of course, this is prefigured in the new Lancet Global Commission on Global Mental Health, which I strongly recommend that you read. It came out in October. And it's very much linked the global mental health challenge with the new Sustainable Developmental Goals. You know, we have goal number 3, which promotes, I think it's about health and well-being, and for the first time names non-communicable diseases and mental health problems as being central in Sustainable Developmental Goals. But more than that, there's the goals about decent work or goals about schooling. And I think that the frontier of our work is on linking the mental health, achievement of mental health goals with these other developmental paradigms. And that's what the World Bank wants. That's what big donors want. They don't want to see mental health ghettoized into its own little corner, because they know that there's going to be a bigger return on investment by linking these different goals together. And so I think social workers are very poised to do that. That being said, this came up last week in Tajikistan, where I also work. There is no school of social work in Tajikistan. There are no social workers in Tajikistan except the ones that were trained abroad and came back there. So I think that your challenge, should you choose to take it on, is to build good schools of social work in these countries. And to think regionally. So you may not be able to do it in every country, but train people in Azerbaijan and send them to many other places as well.
Great, thank you.
Did lunch make you tired? Yes. Can you talk a little louder?
Not really a comment, but just on a couple of slides, the word mothers was spelled, I think the punctuation was in the wrong place.
Oh.
Just for future.
Okay, thank you. I need editing, that's for sure. Okay.
At this particular time in human history, the world is completely out of balance on a scale that we haven't seen in a long time, if ever. And the idea of community, living within a holistic framework of community, a healthy community, is something that's even being lost here in a so-called advanced country. Dysfunction is becoming normal, and it's worldwide now. We need a new system, new way of thinking about the systemic problems that we face. Capitalism is not doing the job. That may be the fundamental problem. If the economic system is not balanced, your society is not going to be balanced. It's not going to be healthy. We're seeing that even here now. So perhaps ultimately the question is, which systems promote health, both mentally, emotionally, within nature, within community, within family, within oneself, without requiring exploitation of nature, each other, oneself, your fellow man. So,
Well,
Mary?
I think refugees, migrants, and asylum seekers may be, the canary in the coal mine in terms of the most extreme cases of people who are being tossed out of society. But I would say in a positive sense, I think that some of the strategies that we learn from them and that they show us they do for themselves are strategies that could be used in a domestic context for dealing with, all kinds of different displacements, gun violence, things like that. So we have a lot to learn from them.
We have time for
Yep.
one or two maybe more questions.
Sure, yeah. I had a question. So you talked a lot about the role of faith and the belief systems of supporting families kind of within their structure. And I was curious if throughout your research, if you learned anything about how that can also serve to connect them to their surrounding community, where, in Turkey, for example, or elsewhere, whether that faith helps them bridge their surrounding community.
Faith or like being a part of a faith community?
Yeah, faith
Or-
community, yeah.
That's difficult to answer. I think that that it's good to have a place. It's good to have an institution that you call your own and that it's your safe space. And that's how many of these refugees feel about the mosque. And though it's gendered, it's more for men than for women. So that's an issue. And it's how others, say, Mexican migrants, feel about the church. And when there's very few institutions they can trust or count on, those institutions are of value to them. But for the most part, not integrating with other Muslims, so it's not like Syrian Muslims are praying with Turkish Muslims. So it doesn't transcend that kind of boundary, at least not yet, but maybe it has the potential to. And maybe that's an area where work could be done.
One more question.
Mary has one, I think.
Thank you for your great presentation.
Thanks.
Really enjoyed it. So one area that I'm interested in is how we think about the social relational consequences of war and displacement. And I was curious for the intervention in Turkey with the multifamily groups. Was it multifamily groups?
Multifamily,
Yeah.
multiple family, yes.
Multiple families.
Either one.
I was interested to know if you had tracked at all rapport or bonds between families that developed in the course of the intervention, and any observations that you had about that.
We intend to track that this time round. We did track that before with cafes, and they did maintain contact with families, and we encouraged that. So I believe there were statistically significant increases in their social network, and that was intentional. Sometimes, these groups that we do, like in a group psychotherapy model, like old school group psychotherapy, you don't want them to meet, When I say the group's over, the group's over. But in these cases, you want them to keep going. You want to encourage that, and you want, the parents to babysit for the other parents' kids and that kind of thing. So we'll see if we succeed at that this time around, but I think that's important. You sound like you have some good ideas. We have some similar interests. Maybe we should meet up afterwards.
Maybe we'll be able to do that, yes. All right, well, join me, please, in thanking Dr. Weine.
Thank you. Thank you. Thanks for the opportunity.
Obviously a lot of interest.